tell you that.
Have you guys been seeing the videos on YouTube? No.
Yeah, I went back to see him.
Yeah, no, you subscribed. Because I get a notification when I have a new subscriber.
Nice.
So yeah, the last day person was you.
Yeah.
Okay, so like I was saying, so there are going to be some changes that occur naturally with aging. You also have Alzheimer's, which is not natural. It happens, but it's not a natural occurrence that happens with all old people. Okay. Now, if they have a caretaker or whoever they live with, or whoever takes care of them, whatever the case is, if they're sounding altered to you, check to see if that's normal. And if it is, okay, then, obviously then that's not the issue of why they're altered today. It could be something else. Now they say, if you ask them, are they normally this way? No, usually they're with it. They're sharp as a tack. And just today, it just seems different. There's your baseline. Now you have something to go by. Okay. Ask them when the problem started. How long have they been like this? Because that's going to lead us into a stroke, or at least the questioning for a stroke. When was the last time they were seen normal, for example? And I'll expand on that when we get to strokes. What medications are they on? Or are there any new medications that they're taking? Because they might be more lethargic due to a new medication. What else? Maybe they're drinking more. They're intoxicated. We talked about medications. Maybe they're taking a few too many. They might be having pain, and they took a few too many because of extra pain, and now they're out of it as a result.
Could you possibly ask about like if they're taking medication along with them drinking? Like, the side effects of what medication can like affect certain things.
Well, you will generally, because you want to find out what medicines they're on. And so part of what's going on today, well, they've been drinking more than usual. Okay. Has anything set them off to cause them to be drinking more or to go on a bender? And then, do they have any medical problems? Do they take any medicines? Are they allergic to any medicines? So that's going to be a natural progression. If you saw that lineup.
Well, what if they're unconscious though? They can't tell you though.
Then who reported it? So we'll ask the bystander or the reporting party what they know about them. We'll look for clues as to medicines that they might be taking. Short of that, then if we can't determine that just by our observations, looking around, then we're not going to have that information. And they'll do that at the hospital. They'll draw blood and they see what their blood alcohol content is, if they're under the influence of any drugs. So did that explain?
Yeah.
Yeah.
Okay. Mm-mm-mm. So going back to Sequoia's unconscious patient, what kind of assessment are we going to do?
A rapid
Rapid what?
Head to toe.
head to toe.
What do we call it though?
Rapid trauma assessment?
But do we suspect trauma?
No.
So what do we call it?
Rapid medical.
Rapid medical assessment, which looks like just like a
Trauma. Rapid trauma.
rapid trauma assessment. As you're doing your assessment, you want to look at the pupils. Are they equal? Are they reactive? Are they sluggish? Are they unequal? So are they equal or unequal? Do they respond, constrict at a normal rate, or are they sluggish? What's their pupil size? You want to check the respiratory rate. Remember the rate, rhythm, and quality? What if their respiratory rate is abnormal, irregular?
Then you follow up with O2 or
You bag them.
Okay, maybe. You have to be careful though, but okay. How about blood pressure? Checking their vitals, right? Now, here's a pro for you guys. If the blood pressure is elevated and you have a widened pulse pressure, what's the pulse pressure again?
Difference between the systolic and the diastolic.
And diastolic. So if you have a widened pulse pressure, then that usually indicates a neurological issue.
it was neurological. What? I'm sorry.
If you have a widened pulse pressure, it's a not neurological issue. I mean, it has to do with the nervous system. Something else to look at, although this can be trauma, but when your person is not it's not alert, and then we do verbal stimulus, and still no response, then we do painful stimulus. Well, what if they tense up their muscles? So what's going to happen is going to be either what we call decorticate posturing or decerebrate posturing. The decorticate is also flexion. So they'll bring their arms up and create like a T. Their arms are brought up. Whereas decerebrate posturing is extension. So their arms, it won't be up in the air, it will be along their sides, and they'll just extend. You'll see the hands kind of curl in this way. And then the feet will also kind of curl up. And that's what we call posturing. Okay. Now, other medical things that we'll see is stiff neck, maybe bleeding in the mouth. What would cause bleeding in the mouth?
Trauma.
Okay, what else?
Biting of the tongue.
From what?
Having a seizure.
From seizures. So you always want to visualize the mouth to make sure you don't have any loose teeth or any type of bleeding in the mouth. Now, and this is going to go with strokes, but we talked about nervous control. in how the nerves control muscular contraction, right? Muscular actions. So if the person went unresponsive, they've lost their RAS, reticular activating system. What other muscular functions are going to be deficient?
They defecate on themselves.
Okay. Or,
They pee or poop on themselves.
well, defecate. Defecate is bowel movement, isn't it?
Yeah.
And so peeing on themselves, urinating. So yes, so their bowels will become, the bowels will open up because the sphincter muscle that's no longer keeping everything in is going to relax. And same thing with the muscular contraction within the GI tract. Those muscles are no longer taut; they're relaxed. Things flow out. Same thing with urine. So incontinence, we call it incontinence, is just loss of muscular control of either bladder or bowel movement. And we say urinary incontinence, or you could technically call it fecal incontinence, but you could also say they had a bowel movement, or incontinent to stool. So what do you think we would do for our altered mental status patients as far as care? So we're altered. One of the things that might be happening is what? Hypoxia. So how would we take care of that?
Oxygen.
If
If they're less than
Both
94.
Well, if you say less than, it would be less than 95%. Or you could say 94% or less. Okay, what else? So make sure you have an open airway, maybe insert a airway adjunct if need be. You want to breathe for them, either oxygen or BVM, depending on what it is. You want to get a pulse ox on them. Want to check the pulse. Pulse might go back to normal with O2. Properly position the patient. How do you think that you would position them?
Recovery position.
Okay. Any other ways?
Would you elevate the legs?
If they're hypotensive, yes. You're treating for shock. I'll think of it. So in your reassessment, how often do you think you want to reassess them?
5 minutes.
5 minutes.
5 minutes.
Probably every 5 minutes, because they're altered for a reason. And if we can't figure out why they're altered, then yeah, let's start checking to see why they're altered. Okay. What else? Get your BTL. You could help out with sugar if sugar is needed. Respiratory. Okay. So not much else there. So any questions in this first part?
No.
No, sir.
No.
Okay. So next up is stroke. Hold on, let me turn on my AC because I'm dying in here. It's like yesterday wasn't too bad. I'm gonna probably have to spend like $300 on electricity this next bill. Be right back. Write this shit down. Oh. Okay, so next up with strokes, and we're going to talk about neurologic deficits. Now, a stroke, also known as a CVA, cerebral vascular accident, that occurs because blood flow is interrupted to a part of the brain. Now, the big thing about CVAs is that the deficits, or basically anything that is not present or is affected as a result of that CVA, it's those deficits that are present that we can see. Now, somebody's not going to have all the deficits, because the thing about CVAs is the deficits depend on where in the brain the CVA is occurring. Okay. Where in the brain is the CVA occurring? Now, if you think about what's happening in the brain during a CVA, lack of blood flow to a particular part of the brain. Okay. Now, give me some functions that the brain controls. And we already talked about bathroom. What else?
If someone has a stroke, they have the inability for like to move their arms or some kind of body part.
Okay, so muscle paralysis, muscle weakness. What else? Difficulty swallowing, slurred speech, vision problems. What else? So blurred vision, slurred speech. Okay, I just muted everybody. Too much noise. So yes, so think about where the brain is controlling. Brain controls speech, so there might be slurred speech. There might be no speech. We have what we call, and what Sequoia said, but the technical terms are hemiparesis and hemiplasia, where it's weakness in one side of the body, hemisphere, so one side, hemiparesis. Hemiplasia is paralysis of one side of the body. You have facial droop.
That's all part of like the muscle failure, right? Like
Correct.
facial droop and all that.
Uh-huh.
Oh, okay.
But when you list it, just muscle failure is not going to be sufficient. You got to tell me what kind. You got to be specific.
Right.
Slurred speech, difficulty walking, which is dystaxia. And then you have difficulty walking, difficulty expressing yourself. So difficulty swallowing is dysphagia with a G. Think about G as in gastric or gut. Difficulty swallowing. And then dysphasia with an S, think about speech, where they're having a hard time speaking clearly. Rapid involuntary eye movement, not necessarily. Now, you can have unequal pupil as a result of a CVA, especially if there's pressure being put on the optic nerve, or it's affecting the vision of that side of the brain.
Would they get red at all?
No.
No,
Uh-uh.
it's just pupils.
Yeah, people's one they could become unequal.
Like cross-eyed?
What was that?
Like cross-eyed?
I mean, there are things that can cause that, but when we're looking at signs and symptoms, we're not necessarily going to be observing for what do they call it? Diplopia? That's what it is.
But what if a patient who has, I don't know, the eye condition where their eyes are like cross-eyed, but they're seeing straight?
Yeah, but that's not a result of a stroke. That's a result of something else.
Well, like I guess that's why she like if it was part of unequal, but it would be more like one's looking
No,
down.
the unequal is it's not cross-eyes. Unequal is
Right.
one pupil is big, constricted, or I'm sorry, dilated, and the other one's constricted. So that's what the unequal pupils is. As far as being cross-eyed, no, that's not. That's more of an ocular motor type of thing that it's keeping the both eyes from being equal or looking at the same place. But no, that's not going to be a result of a CVA.
So you're just looking more at the pupil and what it's doing on the inner part.
Exactly.
Like,
Exactly.
constricted or not. I got you.
Okay. So what else? Blurred vision. Oh, your blood pressure's going to go up. And like I said earlier, neurologic. So your pulse pressure might be wide.
Isn't that what causes like the onset of the actual stroke?
Not necessarily. No.
No.
Nope. It could be caused by a blockage of the arteries in the
Oh,
brain.
okay.
So no, high blood pressure, not necessarily.
And then from there, it would jump up if it was caused by that, right? So I guess it would be.
What do you mean? And you have to be careful about trying to determine what's causing it. That's not our job. Our job is to recognize a stroke and get them to the hospital as quickly as possible.
Okay, just document this sign. This.
Yeah.
Okay.
Yeah. The important thing for us as EMTs is to recognize the fact that they are having a CVA and then making the notifications and getting them to the hospital as quickly as possible. Here's why. Remember I mentioned about the onset, the time that it started, last time they were seeing normal? We have about 3 hours from the time that the symptoms started to the time that they start getting treatment for it. More than 3 hours, they're no longer a candidate. I remember we were talking about fibrinolytics with heart attacks. It's the same thing here if it's caused by a clot. If it wasn't caused by a clot and it was caused by bleeding in the brain, then they have to go in there to try to stop that bleeding if it's possible.
So what is? How can like the ones who get paralyzed on one side at times and they're not able to rehab back from that? What causes most? Is it
That could
time?
have been a bleed.
So it's the time frame that it was happening.
Correct. Well, what do you mean?
You giving up like so if it takes longer to get to the hospital and try and get the help for it, is that a part of it, the time frame?
Yeah.
That might cause it to just not go away or them to not get that
Yes.
motor function back.
Yes, because you have 3 hours from the onset of symptoms. So if you get into the hospital, let's say it started 2 hours ago, but it took you an hour to get to the hospital, you're already past 3 hours. And the to qualify for fibrinolytics or TPA is onset of less than 3 hours. Because what it does is it helps break up the clot. Now, what also has to happen in order for them to be able to get the medication is it has to be a clot. If it's caused by bleeding, what's the body's normal response to bleeding, to blood loss? And I'm not talking about going into shock. What is the normal process of the body? We talked about this the other day, didn't we, in shock?
It'll try to clot it?
We'll try to clot it, right, to stop the bleeding. Well, if you give a medication, or they'll do it at the hospital, if they give a medication that eats up blood clots, what are you doing to this hemorrhagic stroke?
Making it worse?
You're making it worse. You just ate away the clot that the body's been working on for the last whatever amount of time. And so it only works on clots. Okay. Now, the other thing on that is part of the time is, like I said, 3 hours. Number one, from the time the patient gets to the ER, the goal of the hospital is to start that TPA within 45 minutes of arrival, or actually a little bit longer, because they need to have it interpreted, the head CT, non-contrast head CT, interpreted by the radiologist within 45 minutes of arrival. So you see how, yeah, other things that can eat up a big portion of the clock?
Mm-hmm.
Okay.
Yeah.
So the time has to be right. It has to be an occlusive stroke. The only way to know is by doing a CAT scan. The other thing is the last time they were seen normal. When we're trying to determine the time of onset, we need to determine the last time they were seen normal. So for example, I went to bed at 8:30, but nobody knew I was around or alive until about 7:30 this morning. Okay. So that's 11 hours. And at 7:30 this morning, I'm like, I got facial droop. How long ago did the symptoms start?
I mean, you went to bed at 8, you said?
8:30. When I'm off, I spend time on my bed.
how would you, if the person can't speak the way you're speaking, how would you get your answers?
Hopefully they have a caretaker
And if
that
they
you
don't?
could ask them. If they don't, then you can't establish the time. You just can't establish the time.
So what would you put down? That's as your time though. When you first notice it, when you first notice the
No, because we don't know when
Time
it
of
started.
arrival?
You have nobody to tell us. So it's an unknown period of time, so they're not going to do it.
Oh, okay. So you just document that it's unknown.
Yeah. Here's why. The medicine that they give is actually, as time goes by, the risks outweigh the benefits of giving that medication. So that's why it's not given after a certain period of time, because the risks of having issues are greater. Now, those risks include, like we mentioned earlier with the MI, is any recent surgeries, any bleeding disorders.
Mm-hmm.
those would be reasons, contraindications for them to give TPA. All right, what else?
So OTK was the surgeries and what else?
Any recent surgeries? Time greater than 3 hours? Any bleeding disorders? Okay. So the deficits is what you see as a result of the nerves not sending the signals appropriately because the brain is affected in some way. So the blurred vision, the double vision, you can have nausea, vomiting, you could have incontinence to urine and stool. You could have hemiparesis, hemiplegia. You could have tachycardia. You could have slurred speech, dysphagia, aphasia. So the person can't express themselves, usually verbally. So going back to establishing the time, if you can't establish the time, you can't establish the time. So let's say there was a caretaker. Again, I went to bed at 8:30. I turned off the TV and turned over to go to sleep, and I was asleep shortly thereafter. But I wasn't seeing normal again until 7:30, or I wasn't seeing again until 7:30. What was the last time seeing normal? At 8:30 at night. So it kind of sucks, but that was the last time I was seeing normal. So we don't know if the signs symptoms started 5 minutes ago. All we could prove is that they were normal for this case about 13 hours later. No, 11 hours later. Is that past the 3 hours?
Yes.
Yeah, it is. All right. So, like I said, actually, let me back up a little bit. And so there are two types of CVAs. There's the occlusive CVA, which is a blockage, a blood clot, that's disrupting the blood flow to the areas distally from where the occlusion is occurring. And so the treatment is to eat up that clot. The other type of stroke is what we call a hemorrhagic stroke. In other words, the person is bleeding out. And that could be caused by excessive high blood pressure, where that pressure is maintained elevated, and eventually that blood vessel bursts. So, occlusive and hemorrhagic. Let's see. How long can you have symptoms before you're having a stroke? You could be having the stroke while you're having the symptoms. So now they have what they call mini strokes, and it's they call them precursors to a stroke, and that's because the person might be about to have a stroke. It's kind of a warning sign. And we'll talk about those in a little bit. All right, so like I said, our biggest responsibility with strokes, identifying strokes, is just that, being able to identify the fact that the patient might be having a stroke. American Heart uses FAST. facial droop, arm weakness, speech difficulty, and then time to call 911. The goal here is to get them to the hospital as soon as possible. So recognize the fact that they are having a stroke and get them to the hospital. Okay. Now, with with a hemorrhagic stroke with bleeding, one of the ways that the patient's going to describe their headache or their issues is they're going to describe as having the worst headache ever. See what you started, Sequoia. I see you yawning. You got me yawning.
Everybody's gonna yawn now.
Yep. We actually woke up the roosters this morning, so
I know.
and they're mad at us. We want to establish the time. We are trying to get them to the hospital within 3 hours after the onset of symptoms. That is our job. Recognize that they are having a stroke and recognize that we need to get them to the hospital as soon as possible. Okay. All right. So is high blood pressure the only cause of that hemorrhagic stroke?
No.
What else can cause a hemorrhagic stroke?
Aneurysm.
An aneurysm. Yep. What is an aneurysm again?
A floating clot.
What was that again?
The balloon.
It's a ballooning of an artery.
Yeah, the weakened artery. Or
Mhm.
it's like when it ruptures too.
Okay. And so with it rupturing, now it's bleeding out. And that's why, as I was saying, they'll describe it as the worst headache of their lives. So that's why with headaches, it can't just be, oh, you're just having a headache. No, why else or what could be causing that headache? And so looking at remember the general impression, anything about them bugging you? So if they're, I'm not going to say elderly, but if they look like they might be having a stroke, think about it. Although strokes can happen at any age, but if you have a middle-aged dude that's balding, smokes, and drinks, I just don't drink. Could they be having a stroke? Yeah. Okay. So, what about we pause right here, take a break, be back at 10:15?
Yeah.
Sounds good.
All righty. I'll
Alright.
see you guys in a little bit.
All right.
All right.